Hello, my name is Mariya Miteva and I'm going to talk about trichoscopy of scarring alopecia. So scarring alopecia differs from non-scarring alopecia by the absence of follicular openings. You can see here on the pathology that there are fibrotic tracts that correspond to this loss of follicular openings on trichoscopy. It's very important to use the dermatoscope to select the optimal site for the biopsy, as you know that in scarring alopecia, biopsy remains the golden standard for making the diagnosis. So taking the biopsy from an optimal site allows the dermatopathologist to make a better clinical pathological correlation. It provides a better diagnostic yield. And this is a paper that discusses the optimal sites in the different conditions like Lichen planopilaris, frontal fibrosing alopecia, lupus, folliculitis decalvans, central centrifugal cicatricial alopecia. So let's start with Lichen planopilaris. It usually starts with a single patch on the vertex of the scalp. It can have patchy and diffuse and patchy forms. Trichoscopy is very useful to make the diagnosis or to suspect the diagnosis in the clinic. You can see here that the most common features are the presence of these so-called peripilar casts, which are layered scales like an envelope. They encircle the emergences of the hairs from the surface. You can see also broken hairs. You can see peripilar or also perifollicular erythema, which corresponds to the inflammations in the skin. And the affected hair follicles are usually organized in mini tufts or groups of hairs that come out from the same infundibulum, and they're usually surrounded by these peripilar casts. It is not uncommon, usually in 50% of the affected scalp in the patches, we see so-called pili torti hairs. And the pili torti hairs are flattened hairs with 180 degrees irregular twists, like shown here in the picture. And you can see that they can be single or they can be organized in mini tufts. Usually start your exam of the scalp with dry trichoscopy so you can visualize the casts. If you use immediately the interface solution like alcohol gel, you hydrate the scalp and you may miss it. Also, when you take the biopsy, always aim for the areas with the affected hairs. We talk about the dermoscopy guided biopsy. Use your dermatoscope and as you see here, try to biopsy hairs that show features for inflammation, the peripilar cast. Usually these hairs are at the edge of the patch, but not always. That's why it's better approach is to use the dermatoscope. Do not biopsy areas that just show the scarring because the pathologist will not be able to give you more information. This is a nice example of trichoscopy guided biopsy. You identify the mini tufts with the casts, you encircle them with the surgical marker after using the dermatoscope, and then this is where you biopsy. And you see on pathology, this corresponds to follicles, affected follicles surrounded by perifollicular fibrosis and lichenoid lymphocytic infiltrate. These are sick follicles, and they can now be diagnosed as part of Lichen planopilaris. Sometimes we see in Lichen planopilaris these smooth patches that show peripilar casts are not so many, but they have this diffuse dilated reactive vessels forming a network. And you see on biopsy, they correspond to these dilated vessels with some activated endothelial cells. What about frontal fibrosing alopecia? This is seen often in the hair clinic and is actually the most common scarring alopecia we diagnose nowadays. Remember that normal frontal hairline has preserved vellus follicles, and you see on trichoscopy the vellus hairs. An abnormal hairline loses the first thing that happens, it loses the vellus hairs, and you can see that this on biopsy corresponds to absence of vellus follicles and actually follicles surrounded by lichenoid inflammation and fibrosis. You can see on this image several of the features seen in frontal fibrosing alopecia. Loss of vellus hairs, then we have this transparent emergences of the hairs. You see how the hair comes out on the surface through the skin. You can see actually the emerging hair because the skin is also thinner. We have peripilar casts. Usually the hairs are not organized in mini tufts, they're single. We have pili-torti-like hairs, and the most striking feature is that we have follicular dropout. On trichoscopy guided biopsy from the hairs surrounded by the peripilar casts, we are able to see that even if this follicle still retains some of the sebaceous glands, they're showing features of active lichenoid inflammatory infiltrate and perifollicular fibrosis. So we are able to capture the affected follicles, and with confidence we can make the diagnosis of frontal fibrosing alopecia. The sideburns usually lack peripilar casts, but you see these transparent emergences of the hairs. In patients with Fitzpatrick skin types 4 to 6, it's not uncommon to see this peripilar hypopigmentation rather than peripilar casts, so keep that in mind. This is not specific to frontal fibrosing alopecia. It can be seen also in lichen planopilaris and in centrocentrifugal cicatricial alopecia. And we see this vessel network in FFA, which is basically a clue to this atrophy in the skin. Why? Because with the dermatoscope, we are able to see the ramifications of the vessels coming from the superficial vascular plexus, which is parallel to the skin surface. In very early cases, in subtle cases, in tricky cases, we may have retained vellus hairs, but look a little bit behind the hair margin, the fringe of the forehead, and you can identify this peripilar cast. So you have to take the biopsy in such cases, for the peripilar cast, and in such cases we see this perifollicular lichenoid inflammation, even without perifollicular fibrosis, affecting the vellus follicles. In traction alopecia, you know that we have this empty infundibula that you see like these brown circles in the skin, and we have hair casts. The hair casts are basically corresponding to active traction, and actually they correspond to the hair shaft, the hair sheets that are actually surrounding the hair shaft and coming out on the surface. So on the biopsies, we can see intact sebaceous glands, and we have follicular scarring. So the sebaceous glands are preserved in contrast to the other scarring alopecias where they're gone. What about CCCA? We have peripilar white-gray halo. Of course, look for drop of follicular units, follicular dropout, that's the main feature. And then we have this peripilar white-gray halo surrounding the emergent hair shaft. We have pinpoint white dots, which are basically the openings of the small follicles and the glands on the surface. The white-gray halo is smooth and round and corresponds to concentric perifollicular fibrosis. And the broken hairs, which we can see, are also very good site to take the biopsy from because they correspond to affected and destroyed hair shafts. This is a classic picture of CCCA. On the biopsy, we see all these affected follicles surrounded by perifollicular fibrosis, usually less than lichen planopilaris, but in this case, pronounced lichenoid lymphocytic infiltrate and a lot of follicular dropout. In discoid lupus, we have different features. One of the most prominent is keratotic plaques. You see the infundibular plaque by keratin. Or we can see blue-gray speckled dots, which basically are these pigment incontinent dots coming from the interface involvement, the vacuolar damage, and they can be in this speckled pattern because the interface goes also in between the follicles. Thick arborizing vessels are seen in discoid lupus in the center of the alopecic patch. Remember that in Lichen planopilaris, these vessels are usually linear and they're at the edge. On biopsy, we can see this prominent inflammatory infiltrate with red blood cell extravasation centered around the affected follicles. And on dermoscopy, this corresponds to so-called follicular red dots, which are considered specific for discoid lupus. What about yellow dots with the red spider? You can see these big yellow dots and these thin arborizing vessels around them. When you see this, do not mix this with alopecia areata. Always take a biopsy because this could be a patch of lupus. And I'm going to show you an example of a patch treated for alopecia areata with lights and steroids for 1 year. You're able to see the thick keratotic plaques, and this is why you have to take a biopsy, because this is not alopecia areata. You see the interface inflammation of the follicles, making the diagnosis of discoid lupus. What about folliculitis decalvans? It corresponds with this, it presents with this thick bunches of hair that are called tufts. Usually 6 or more hairs form polytrichia and come out of the surface. This should not be mistaken with dissecting cellulitis, even if both conditions represent neutrophilic scarring alopecia, because in dissecting cellulitis we have completely different features. We have patches, hairless patches that actually can mimic alopecia areata at the beginning. They present with these 3D yellow dots, which are basically quite larger and keratotic, some broken hairs and erythema. If you look at more pictures on folliculitis decalvans here with interface solution, we eliminate the scales and we see these concentric perifollicular vessels in a starburst pattern. This polytrichia corresponds to compound follicular structures on pathology. Thank you very much for your attention.